Dear PhD students, ladies and gentlemen, first of all, I would like to thank to organizers, to Professor Peter Hergy, and more especially for inviting me at this unusual experience for me that I like very much. This complex evaluation of the PhD students. We have a program for sure in our University of PhD program, but here that is different, is this kind of evaluation, and I appreciate very much your high level of the presentation. So listening you, and on the other hand, looking at the presentation of Alexander concerning the program, I changed it a little bit, my mind. I changed it also, my presentation. So at the beginning, this title, From Cognition to Research, seemed to be, to me, being very important, but I saw that you used to make a translational research, so I'll change it, that I said a little bit my presentation. In the first part, I'll speak a little bit only about the path that we have to follow between cognition, and this concept is different from knowledge, to research. According with Plato, for instance, cognition means overcoming appearances to seize the essence. So it does not resume to rational information and experiences. And on the other hand, Descartes told that long time ago, but very actual, actual also now, that the cognition naturally belongs more to our spirit and is elaborated by our intellect, starting from sensitive matter. So it's an activity that satisfies the pure wish of knowing without an instant practical utility. But between cognition and this utility, so the satisfaction of needs, there are a lot of steps, and between these steps, there is an important relationship. And one of the most important is the research, because research supposes to be a systematic process of collecting and analyzing the information to improve our understanding of a particular aspect. Checking a little bit literature, you are used, and you used this checking of literature in preparing a lecture. So I also surprised when I discovered this statue, in wood statue, which is located in the Great Hall of the Thomas Jefferson Building, in the largest, I think, library in the world. Is located in Library of Congress, Washington, D.C. So this statue represents a lady, which is, in fact, is the research, which carries a flame, a torch, which represents the science. So science, we can say, is a door whose key is research. And according with this gentleman, a very important one in the world, in American world, science is the art of finding solutions. But in this way to finding solution, we have to discover, to answer at some problems, and you already discovered these problems during your research. So it is important to find this approach to look beyond what we already know. So to find a problem without answer until now in the field of the knowing already know, but it's very important in our thinking to respect the truth. It's very important because this concept is important in our thinking. On the other hand, our research project could respect the simplicity, elegance, and even beauty in their formulation. And we have to pay attention at the final conclusion because, also I appreciated in your presentation that sometimes we start from a problem non-answered until now, and we try to find an answer. But it's not very important to discover the answer, being positive or negative. It's very important to pay attention to this C point, intermediate point, because sometimes an answer could raise another question. And this is very important during a research. So this, and I am, you are especially very, very happy to have with you a statistician. And so Ben Szabo, for sure, help you a lot, and he knows to discover this doubt, this probability in our research. So that is why we need a right methodology, and this science methodology, in fact, is the art of asking the right questions and to prepare for understanding to answer. So there are different steps. But very important is, I think, the first step to discover, to identify the problem, to identify the research topic. But for that, we have to keep open mind, to have open source, to use open source, and to be every time in connection with the new science, new findings. For instance, we have to use the feature, the findings of artificial intelligence in more and more aspects. So formulating an hypothesis is very, very important. This hypothesis has to be clear, testable, specific, and in fact, it represents the foundation of the research. So hypothesis is the idea about problem that we have to solve based on the previous knowledges of preliminary research. And it is very important to formulate it very, very clear to have a possible answer. So taking account all these concepts, we can imagine that our research is like a cycle, like a cyclical process, starting from identifying the question without answer until our research, defining the purpose, eventually to divide this initial problem in sub-problems, after that to make the research, to analyze, and again, it is very important to have a statistician close to you to interpret the data, and after this, being able to write a paper, and a paper that could be accepted by an important journal. But at this point of interpretation, of finding the answer, very important is identifying this doubt that I spoke a little bit earlier, because we can identify another question and we have to continue our research. So I think it's better to think to our research like an helical nature, a spiral, not a cycle, not a closed cycle, in order to have this open mind for different other questions that could be raised. So I assisted even yesterday, and also I follow even today a very nice project, and with a good objective, good research plan of research proposed, but especially in fundamental science, so in fundamental research. But we can do also in clinical research, not in consulting the documents, old documents, but clinical research could suppose, for instance, an epidemiological study. And I will exemplify my thinking with the study, epidemiological study that I built the Romania Society of Hypertension, and I was the president for many years. And in this position, I did this epidemiological study, starting from a problem that we know very well, that cardiovascular disease represents the main cause of the mortality over the world. But in Romania, this mortality, cardiovascular mortality, is over 60% as a cause of total mortality in Romania. So because of that, Romania is put it on the map of European countries in a very bad position, noticed with red. So it's a country with a very high cardiovascular risk. Hungary is in a better position. So why do we have this situation? For answer to this question, we have to know, to identify the cardiovascular risk, to identify the causes of this high mortality, of this high risk. That is why we did this epidemiological study. It's not only one. During 16 years, we did 4 studies, epidemiological studies, called SEPHAR, the Study for Evaluation of Prevalence of Hypertension and Cardiovascular Risk Factor in Adult Population in Romania. And the last one was done in 2021. During pandemic time, we planned to have a follow-up study. We couldn't because of the pandemic time, but all of them, is very important, have the same methodology. So the same methodology, supposing that they were so a cross-sectional survey, multi-stratified sampling. So we choose the subject totally in these 4 studies were involve almost 8,000 subjects, adult subjects between 18 and 80 years old. They were selected based on age, sex, and location. Location, cities or villages, 24 cities, 24 villages, and also based on the income of this subject in specific regions. So we went to each location using this mobile medical office named SEPHAR bus, where we did all the investigation that I'll present, and also with very good and dedicated staff trained for in order to obtain these results. So the methodology was done to respect, so for all this subject, 2 visits, a 4 days interval, because we assess, respecting the rules of European Society of Hypertension, the measurement of the blood pressure, so a 4 days interval. The first visit takes 90 minutes, and after the subject included, so after he signed the informed consent, he fulfilled, or she fulfilled, a very complex questionnaire about 80 questions. After that, we measured the blood pressure. We measured also the anthropometric, so the height, the abdominal circumference, and also the weight. And in the first visit also, we did ultrasound, carotid ultrasounds. In the second visit, for all this subject, we measured also electrocardiogram 12 leads, transthoracic echocardiography, and in a fasting way, we collected the blood samples for checking the lipids, also ApoB, ApoB, and ApoA, also glucose and hemoglobin, glycated hemoglobin, also creatinine and potassium, and we collected also from the spot urine sample. We collected the urine samples, analyzing the level of urinary creatinine, and also the sodium, the quantity of sodium, for appreciated using Kawasaki formula, the salt intake for every patient, for every subject. What were the results? So the prevalence of hypertension in Romania over 16 years period, from 2005 until 2021, continues to be very high, over 45%. In the last SEPHAR study, almost 46%. Even the prevalence is higher, as you know, in adult and in older age, but even this prevalence continues to be very high. Even the patients, hypertensive patients, were well treated. They were also better controlled. So you can see the control is almost double in the last SEPHAR study, from 20% until almost 40%. So it's a good news. But but the prevalence continues to be high. So another question that we identify is, why is the prevalence continue to be so high? And we identify two main causes. One of them is salt consumption. So as I told you, we calculate this salt intake using the Kawasaki formula from the urine sample. We saw that, and it was maintained, the salt consumption is very high. Average is between 10 and even 11 for the general population gram per day, but for the hypertensive people, this consumption is very high, even 14 gram per day. So it's huge, very huge consumption. Even we have now the recommendation coming from the European Society of Cardiology or American Society of Cardiology and Hypertension. So the level, the highest level admitted is until 6 or at most 7 gram per day, but better is around 5 gram per day. But who respect these rules? I know only one population who adapted their consumption to these rules. Is the population coming from Portugal, so Portuguese society, because they had a very high prevalence of hypertension and very high prevalence of stroke. Using and applying by law, because only by convincing people is not, we didn't succeed, we would not succeed, so they apply by law and they succeeded to reduce the prevalence of stroke with about 7% during 12 years. So we have here the acronym, we have here the measure that we have to apply, but it is important to be put it in a law, and our government started to make a such law. If not, we cannot succeed to have to reduce the prevalence of hypertension. Another cause for such high prevalence of hypertension is obesity. Obesity, independently, how could we measure by the level of BMI or by abdominal circumference? We can see that the prevalence of obesity was higher and higher, and we know that the obesity by different mechanisms leads to arterial hypertension. Linked to obesity, linked to salt consumption, we have also a high level and higher level of dyslipidemia and also of diabetes. Hypertensive people has even 30% diabetes. In the general population, almost 14 or 17 percentage. According with this high prevalence of hypertension, dyslipidemia, and also obesity, the percentage also of the metabolic syndrome, according with APT3 criteria, is also almost double in comparison with 2005. So something happens in a bad manner. So it's not surprising now that Romania continues to be in a very high risk, cardiovascular risk zone. If we see this slide, so the hypertensive patients, according with all these criteria, has also a very high or high risk in a big proportions. More than that, in this epidemiological study, we had over 300 young adults between 18 and 35 years old. And they had also a very high risk. We can see that they have dyslipidemia in almost 41%, obesity 30%, hypertension 10%. Being very young, the diabetes was less represented, and plus they are smokers. So also it's not surprising seeing that they reach metabolic syndrome, the criteria for metabolic syndrome in 7%. So it's a very good, very bad news for our population. Even if we compare with the United States, we are in a better position, but it's not the case to compare with them. It's the case to compare with you, for instance. So doing this epidemiological study, we had a real image of the prevalence of the hypertension and cardiovascular risk factor for what? For building primary prevention programs, because we have the secondary prevention programs, and which are doing very well. We reduce the mortality after the acute myocardial infarction, but we need this primary prevention program, and we hope to succeed to reduce our cardiovascular mortality. Our results were very well received in the scientific world in Europe, and not only. So our results were accepted for publication in Journal of Hypertension, in atherosclerosis, even in your journal some years ago, and also they were put it together with another epidemiological study, and in this network of NCD risk factor collaboration, and our results were published even in Lancet and Nature. So the study were very well done, and we can do, that is why I showed you. We have also, and I prepared some research also in fundamental field, but I think it's the case to stop here, and I hope to enjoy this kind of the research too. It's not only in laboratory, we can do in the real life a good research. Thank you for your kind attention.
Well, thank you very much. This fascinating presentation, which covers about 20 years old follow-up and 20 years old work.
Even 16. But
it will.
It was amazing because we started this epidemiological study following the same methodology for the beginning with the colleagues from Poland. They had NatPol, and we had SEPHAR study, and we put it together, the results, we compared the results, and after that we developed our own epidemiological study, even for this young population. Yeah.
Congratulations, it's very fascinating. I always miss this long-term population-wide data as a doctor to think of, for example, in the Hungarian population in any regards. So we know a lot about Romanian population now. I have two questions. That 14% in that young age of smokers seems a bit too small to me. So they are not smokers. 40% would be. Why was that? They are underreported, or?
We extract this group from the whole group of almost 2,000 patients. But we did, after that, we did a survey dedicated only to young population. And the percentage of smoker is much higher.
Okay.
It's much higher. So this is, we put it together, but in the study that we did last year, the percentage of smoker is over 50%.
Okay, yeah.
For the young people, yeah.
And I was
Don't worry, they are like you. Not you, but the young people from everywhere. Yeah.
Okay. And I was thinking on a based on this smoking data, for example, that you were measuring different results on these patients in two parts. So the 90 minutes and the next follow-up 4 days after. Why was this separated? Couldn't it introduce selection bias due to loss of follow-up for the second part?
No, so we divide it in two parts because of the rules of measurement of blood pressure.
So yeah, to have it two different.
And there were different measurements during the first visit and the second one. So only blood pressure was measured in each visit, but it was mandatory, and it is mandatory to have an interval between 4 and 7 days between the two measurements, two sets of measurements. And looking at our colleague statistician, we missed a lot such help, and we fortunately we have a colleague who make in the same time with the medical school the informatics, the faculty of informatics, and he helped a lot. So we need such help, but I have to recognize we had not any financial support from the government. It was only a sponsorship from different companies. Even the cost was very, very high. About 150,000 euros.
So congratulations on that. And just so you had a negligible amount of follow-up between the two.
Unfortunately, we plan the last one to be a follow-up. Because we have an electronic database for all these patients, but because of the pandemic time, it was almost impossible to ask the previous subjects. But in the next year, we will follow up. We will organize another study to follow the patients from SEPHAR 3 and SEPHAR 4. Yeah, so from 2016 and 2021, you are right, and we thought about, but it was, I don't know who brought us the pandemic time. Yeah.
Okay, I also have a question that, do you have any information about the socio-economic status of the patients who are involved in that? And have you tried to adjust the hypertension for that, hypertension data?
Yeah, we have, because putting together our data for this network, so European network is the team from Imperial College who lead and collect all this data from Europe, and they ask us about the income, and we have such information. I didn't present, but we have such information because I told you we had a very complex questionnaire with 80 or 84, I don't remember exactly, the questions. And some of question was dedicated to the income, to the level of education, and so on. Yeah, we have.
And you have to try to adjust the hypertension. For example, if someone is well educated or the income is higher, maybe the blood pressure is lower, or have you found anything?
It's a relationship between the income, the level of education, because it's related with the treatment, with the awareness, and so on. Yeah, okay. Yeah, we have.
Okay.
So congratulations as well. I know it's impressive and tough work to do such a study. I would like to ask, and you also mentioned it in your presentation, like regarding the 5 grams of salt.
Yeah.
So what would be the strategy? I just would tell that, for example, in patients which I care a lot, cirrhotic patients, we have also similar threshold, but I know it's so difficult, and also the malnutrition increase afterwards. So what would be your strategy for this?
Yeah, you know, it is a debate even concerning this this amount of intake of sodium. It is considered a paradox, for instance, if we have a very low intake sodium for the patients with cirrhosis or heart failure. But it is not the case. See, if the target is 6 and we have double, we will be very happy if you succeed to have to reduce with 2 or 3 grams per day. And in Portugal, for instance, they by law they reduces the quantity of salt in the bread, because the bread is very tastable, even in Romania, being very salty. So to reduce the amount of salt in the bread with 2 grams, it's already something did. Also in pre-prepared food, it's very important to reduce the quantity. And we started this cooperation with the industry of food to reduce, and because their problem was not to be so not selling this food, but they could replace the taste of salt with different another I don't know, mirodeni, nu știu cum, what is the word? Huh? Do you know mirodeni? Yeah, no. So something which can replace this taste, continue to be in a good manner kept. Yeah, the taste. Yeah.
One remark for that.
Yeah.
First of all, at least in Hungary, the conserving agent like the sodium glutamate contains huge amount of sodium. That's a problem. And as a clinician, I have already tried to follow the regulations and try to keep the sodium intake less than 5 grams. And believe me, it's unenjoyable. The food is unenjoyable for me as an average man. And I'd like to emphasize for the others that it's impossible to drop down from 15 grams of sodium immediately to 5 grams.
Yeah, for sure.
What I always recommend, to eat fresh food. which doesn't contain sodium glutamate. And if someone wants to replace, maybe the potassium-containing salts are the best solution for that, at least in my opinion, but maybe that's not the...
No, I agree with you. Replaced with potassium, it's very important. And again, we were very happy if you succeed to reduce from 12 to 10 or 9. It's,
20%.
For me, is something non-touchable to have 5 milligrams per day. But it is important to starting to reduce. It's very important to reduce in this way the prevalence of hypertension, to reduce the prevalence of stroke, to reduce the mortality, cardiovascular mortality, because now in Romania the cardiovascular mortality represents over 60% over all the mortality. So it's too much. Yeah.
Hello, thank you very much for your presentation. Just come to my mind one question regarding your questionnaire. Are you asking about the compliance of the patient to the treatment? Because, okay, from my experience, many patients, essential hypertension, quite often have no signs, clear symptoms for the patient. So they have high blood pressure and they don't notice it. So quite often they quit the prescribed drugs. And could it be the potential reason for the high MACE, for example, in these patients? Do you refer to this question as well?
Yeah. So this questionnaire again is very complex. So they have to mention the treatment, even because we check also they take monotherapy or combination therapy and so on, and of adverse event is all of that was noticed, and we can check every time this their answers, but it was not the case to mention now. But we this questionnaire was such complex so we noticed all this fact that you mentioned. Yes, and I work and I participated twice here in Budapest at the meeting of hypertension organized by Professor Ciobo. I don't know he is alive or not, because I have not, no. Yeah, was the president of your society. Even I am the honorary member of the hypertension in your country. But, and we work a lot about the awareness, about the kind of treatment. So we try to put together our results in comparison with other hypertension society, other populations around us. You have a very good control in hypertension here. I know, and the prevalence is almost, I knew, about 30%, and the control was over 40%. So the problem is to reduce this risk factor, so not only the prevalence of hypertension, but also dyslipidemia and obesity. That is why I think this primary prevention program have to start from childhood, from 5-7 years old, not in adult. In adult population, the habits are already there, so don't have the success. Starting from the childhood, it's a good thing. Yeah, you need your help.
Thank you very much.
Could I ask sometimes? Huh?
Of course. Anytime.
Of course, I need your details, your contacts.
So it's a really impressive work so far, and I would say, yeah, it's 16 years, but it's for me it's a really good initiative. You have a really good look at the Romanian population, but you mentioned that the Polish guys did almost the same thing as you, and you could
not in the whole country. We did in whole country. So we went with this bus, SEPHAR bus, everywhere in the located that we choose from the statistical point of view. So from the National Register of the Population. And it was a very difficult process because they offer us only the sex, the age, the location, not the name, not the ID. So we sent triple envelopes with asking to participate at the address. And someone accept, someone not, someone was abroad, and so on. So for having 2,000 subjects, we sent 6,000 envelopes, letters for acceptance. So not knowing who will be. So it was a very difficult process. Very difficult process. So please, sorry for interrupting you.
It's all right. I can believe that it was really hard to organize everything, but I've noticed that you flashed up a map of Europe, and there was a clear geographical tendency in the. So basically, the post-Soviet countries were red, the countries next to the Berlin Wall were orange, and everything on the west was roughly green.
We hope to exit of this red zone from different points of view.
And I'm just saying that you have a really good view on Romania, and I believe the natural progression of this project would be to do this same at every European country, and then you will have because you only see a little slice of the cake now. And you don't know the cover rates of the other countries, the GDP effects, stuff like that. So that's why I say it's a wonderful initiation, and I would go international, go wide with it.
Thank you so much for your appreciation. Thank you.